Welcome to IgE-targeted Therapies and the Future Management of Food Allergies, presented by the Partners for Advancing Clinical Education, broadcast simultaneously on clinicalserieslive.com and immunologylive.com. My name is Dr. Edwin Kim, Associate Professor of Pediatrics at the University of North Carolina School of Medicine. Today's session is interactive, allowing us to take your questions in real time throughout this presentation. We encourage you to enter questions at any time in the box below. I'd now like to introduce my co-presenters, Dr. Ruchi Gupta, Professor of Pediatrics and Medicine at Northwestern Feinberg School of Medicine and Director of the Center for Food Allergy and Asthma Research, and Christy Herring, a parent of a child with food allergies. Thank you, Ruchi and Christy, for joining me today. Let's get started. First, here are our disclosures. And here are our learning objectives for today's session. Clarify recommendations for the diagnosis and management of food allergies. Recognize the limitations and challenges faced by patients relying on allergen avoidance or using immunotherapy to manage food allergies. Summarize current evidence on the efficacy, safety, and place in therapy of emerging biologics that target the underlying IgE-driven pathophysiology of food allergies and common associated comorbidities. And finally, discuss the place and care of agents targeting IgE and the role of shared decision-making in the management of people with food allergies. And with that, I'll let Dr. Gupta take over to tell us a little bit about the burden of food allergy.
Thanks so much, Dr. Kim. So we'll just get started with the prevalence of food allergy in the United States. So currently, what we know is that about 8% of children have a convincing food allergy. And when we talk about what types of food, it is peanut, milk, shellfish, tree nut, egg, finfish, wheat, soy, and number 9, sesame. Important things to note here is that although about 8% have a convincing food allergy, about 11% reported having a food allergy. So they may have other conditions that are not food allergy, but something related to food. And then of those 8% with a convincing food allergy, only about 5% saw a physician for diagnosis. Now here you can see prevalence by age. And some important things I want to point out is that milk and egg are two of the foods we see early in life. So less than 5 years, you're going to see milk be your top allergen. Now, these two foods are also the ones that are most commonly outgrown. So about 50% of kids can outgrow milk and egg allergies, which is great because it's such an important food. The other food allergens we talk a lot about, peanuts and tree nuts, we see them come on, usually when the infant child starts eating them. And these two, you see higher numbers as they get older because it's not as frequently outgrown. Only about 15 to 20% outgrow it. And similarly for shellfish and finfish. I'm going to quickly talk about food allergies in adults. We talk a lot about kids, but what we know in adults now is that about 10% seem to have a convincing food allergy. But interestingly, about 1 in 5, so about 20% reported having a food allergy. So, for all the clinicians out there, this is really, really important because they're not getting diagnosis. Only about 5% had a diagnosis of food allergy. So these may be intolerances or other conditions masquerading as food allergy. So very important to try to pull them in and get a proper diagnosis. Now, when we talk about severity of food allergy, we see that all foods can cause a severe allergic reaction. However, the order is what you see here in both kids and adults. So peanuts, tree nuts, finfish, shellfish, and then the other foods. But again, any of them can cause a severe allergic reaction. I do want to quickly just touch on disparities in food allergies. So we do see disparities in food allergy, and we also see differences in food allergens by race, ethnicity. So something else to really keep in mind. You do see here that shellfish is significantly higher in Asian and Black and Latinx communities. Whereas other foods, are a little bit different. You see that in peanut a little bit, and then also in milk, finfish, and soy. Now, food allergies have a major impact on quality of life, and mainly because food is a part of everything we do. All your meals every single day, but also almost every social interaction. So, at schools, at college, at work, at sporting events, at parties, at clubs, food is usually a part of it. It impacts, your school life, your social life, family relationships, finances, eating out and traveling, and can significantly impact your mental health because there's big anxiety about allergen exposure. I mean, these kids and adults are totally fine, but if they come in contact with that allergen, they could have a life-threatening reaction. When we talk about morbidity, so how many are having those reactions? In our study, what we found is that in kids, about 1 in 5 kids are going to the emergency room every year for a food allergic reaction of kids who have food allergies. And about 40% had been to the emergency room in their lifetime for a food allergic reaction. In adults, about 1 in 10 adults are reporting going to the emergency room in a given year for a food allergic reaction, and about 60% in their lifetimes. Now, importantly, when we talk about income and SES, what we found is that low-income children are spending less on specialty care, getting to an allergist, and significantly more on emergency department visits, 2.5 times more, and less on special diets, special foods, and medications. Okay, now let's get into a little bit of exciting news that we have. Food allergies, in the past 20 years that I've been studying it, what we found is that we finally have prevention and we finally have some treatments, which my colleague Dr. Kim will tell you about. But let's start with prevention. So what do we know? So peanut allergies have consistently been on the rise. Now we, call it an epidemic, but you can see by 2016, we're at about 2% of the general population of kids having a peanut allergy. What are the guidelines? So when we started seeing this trend, probably, early 2000s, late 90s, what happened was the American Academy of Pediatrics put out a statement for all pediatricians to advocate avoiding consuming peanuts until age 3. So pediatricians started saying don't eat peanuts till age 3. Egg was till age 2. And this continued. Now in 2008, these guidelines were revised because there was no data showing that this was effective. And so they said, we're not sure. Do what you think is right. So the recommendation was taken away, but most pediatricians, including myself, just continued to say avoid, seemed like the safer route to go. Until 2015, when the LEAP study came out in the New England Journal of Medicine, showing that early peanut introduction in high-risk infants could actually decrease the development of peanut allergy. In 2017, US NIAID guidelines were developed, which also promoted this early introduction of peanut products. So what are these guidelines? So the NIAID guidelines that were published broke down infants into 3 risk categories. So high-risk infants were those infants with severe eczema or egg allergy or both, and this came directly from the LEAP study. And for those infants, it was strongly recommended to be evaluated either by a specific IgE by the primary care pediatrician, or get them referred to an allergist so that they could do a skin prick test and then determine whether or not to introduce peanut products. Now, any infants with low to moderate eczema, which is 95% of babies, are to be told to go ahead and consume peanut products as soon as they're ready to eat solids, not the first food, but soon after. Now, what we found doing this was that oftentimes there was a delay in getting those infants that were high risk to allergists. And that delay could be, a major factor in them actually developing that peanut allergy, because every month that's delayed, their chances are even higher. So the Quad AI and the college and the Canadian Society came out with a consensus document saying, you do not have to screen before introduction. So even for those high-risk infants, just feed peanut products. What we know is that infants tend not to have a life-threatening reaction. Typically, their symptoms are vomiting and hives, but done under careful observation by their parents, they can catch a reaction early. So currently, our recommendations are really to either take the high-risk infants and refer, or to go ahead and introduce. But for the low-risk and moderate-risk infants, introduce peanut products early. And what we mean by that is peanut butter mixed with either breast milk, formula, applesauce, whatever your baby likes, just to thin it out a little bit so it's easier to eat. Okay, we're going to move into food allergy diagnosis and management. Steps for diagnosis. So food allergy diagnosis is something that has been talked about a lot because we have diagnostic methods, but none of them are perfect. So let's get into this. So the number one part of diagnosing a food allergy is the clinical history. A really solid discussion with the patient about what they ate and what reactions they had. And this is really important because if they ate the food and developed hives, vomiting, trouble breathing, it's very, very much likely that it is a food allergy. Now, if they ate the food and got stomach cramps and bloating, probably not an intolerance. And if they ate the food and got oral hives and itching, maybe it's oral allergy syndrome. So very, very important to understand the clinical history. The next step is the testing. So the two types of testing we talk about a lot are the skin prick tests, which are done by trained allergists, and then the specific IgE levels of each food. And those can be done by pediatricians, internists, primary care providers, and are also definitely done in the allergy office by allergists. Now, there are other pieces of that IgE component testing where we can really select out the specific proteins in each food that may be a little bit more accurate than just a general specific IgE. Finally, the gold standard right now is an oral food challenge by allergists in their office. And that means feeding the food to the child or to the adult under a controlled setting. And then finally, step 5 is what do you do with it? Eliminate the food and educate them in case of an accidental ingestion. Now, food allergy symptoms, the reason food allergy is so complicated is the symptoms really vary. It can be any organ system. So here is a list. So of course, skin, we hear a lot about hives, itching, urticaria, flushing, angioedema. However, hives don't have to happen in a food allergic reaction. And this is really important. At least 50% of reactions, you may not even see hives. So we have often associated it, but make sure you realize that there are other very, very common symptoms. Oral, you tend to get that itching and throat closing, and then the rash around the mouth, but you have to be careful if this is also could be diagnosed, if that is all they're getting as oral allergy syndrome. And then the respiratory symptoms, we talk about cough, wheezing, trouble breathing. Those are also higher in people with uncontrolled asthma. And then GI is very common. In food allergy, it's a lot of vomiting, but you can get diarrhea and abdominal cramping. And then cardiovascular, hypotension, so a drop in blood pressure rapidly, and this is what can be very scary. You can get the dizziness, syncope, and tachycardia, and neurologic, confusion, headache, tunnel vision. Oftentimes people talk about, this impending sense of doom. And then here, as we talked about before, if you only have GI symptoms, it can be an intolerance, FPIES, celiac, gluten sensitivity, only oral symptoms, oral allergy syndrome, which I mentioned, or pollen food allergy syndrome. Okay, so went through this a little bit, but I'll just reiterate. So food allergy, clinical history, very, very important. Over-testing often happens too, so be very, very careful about those panel tests for IgEs. I know those are sold a lot of times as a cheaper option for generalists to test a number of foods at once, but we want to stay away from that because many kids are and adults are sensitized so that they may have a positive IgE to a food, but they can still eat it in their diet. And often when we order those panels, physicians then start taking it out of their diet because they see that high IgE. So only test for foods that you are suspicious of. This is a skin prick test that we talked about. Typically, under 2 or under 3, sorry, they are clear, and so they should be able to tolerate the food. 3 to 7 is moderate to high risk of a reaction, and allergists will often do that in-office supervised feeding or oral food challenge at that point. And if it's greater than 8 millimeters, they are likely already allergic. This is a specific IgE that I just mentioned. Again, avoid those panels. Okay, I'm going to discuss just quickly a patient insight. This is the program that was done with caregivers, and we asked them to receive a food allergy diagnosis. Which tests have you had? And here you can see many of them had more than one test. And this is great because oftentimes allergists use skin prick tests along with blood IgEs, and then depending on the value, may do that oral food challenge. But you can see skin prick tests were about 30%, blood tests were less at 8%, and only about 2% said only oral food challenge. But I am sure many of these 61% probably had that. All right, food allergen avoidance. So this is very, very important for your patients because it's very confusing. So currently the law is that manufacturers must clearly list 9 food allergens, and sesame became one of those after the FASTER Act in 2023. So what are those 9 allergens? It's egg, fish, crustacean shellfish, tree nuts, peanuts, wheat, and soybeans. And then, of course, sesame was added. Now, why is it challenging? It's challenging because although the foods that are in the item are clearly marked, either in bold or underneath that it contains, what gets confusing is the voluntary labeling. So this is call it precautionary allergen labeling. And there are no legal rules around it. Each manufacturer decides what they want to put on the food. So let's talk a little bit about this. What happens with precautionary allergen labeling? There's a couple of them. So what I'm talking about is those may contain labels or manufactured in a facility label. So all of those are determined by the manufacturer. So here you see the question we asked the patients and caregivers in the last session was, which of these makes you feel most confident when buying a food product? Products labeled that lists food allergens in the ingredient list, product label with a may contain, product label with a processed in a facility that also processes, or all of the above. So the majority said all of the above. Now, what gets confusing is here you see 24% said product label that lists food allergens in the ingredient. That's great. And then here you see a little bit said the processed in a facility. Now, we don't know what the difference is between may contain and processed in a facility. And we don't know that processed in a facility is safer. However, many of your patients probably think it is because it sounds safer. So I think this is an important conversation to have with your families on what exactly precautionary allergen labeling is and what it means for them. Okay, so here I'm just going to mention, and then Dr. Kim will go into much more detail about this, but what are current categories of treatment? So there are, we call these 4, the epicutaneous immunotherapy, oral immunotherapy, sublingual immunotherapy, and biologics. And these are the 4 that are up and coming now for the treatment of food allergy. Oral immunotherapy is small amounts increased over time, and it works by gradually desensitizing patients on the dosage. And then there are many challenges for oral immunotherapy. You have to increase the amount you take periodically, and you can have reactions while you're on OIT. Also, a lot of people are averse to that taste and smell because they've been avoiding it all their life. And so it is sometimes difficult for them to initiate it and keep it in their diet. Also, I just want to point out that OIT currently, there's only one that is FDA approved, but it is not always accessible to all patients. So a lot of it is OIT and done by specific allergists in different cities. So just being aware of that, it can be very costly, and there's currently not covered for all patients. So with that, we're looking forward. There's a lot of hope and a lot of new developments coming out in food allergy. I talked about prevention, and I'm going to turn it over to my colleague, Dr. Kim, to tell you more about treatments.
Thank you very much, Dr. Gupta. And so our next section, pathophysiology of food allergies. Really, what we're going to be talking about here is how can we use what we know about the pathophysiology of food allergies to help develop better treatments. And so first, to start out, I think a question is, well, why do we need this? Why do we need new treatments? And here I'd like to bring in Christy just to tell us, first of all, about, well, avoidance, right? This is what we've done for so many years. We've tried to avoid the foods. And we talked a little bit, Dr. Gupta had shared with us a little bit about label reading and what that might be like in combination with avoidance. And Christy, do you mind telling us a little bit about what that experience has been like for you?
Yeah, of course. We started the oral immunotherapy journey roughly 2 years ago. It's opened up a lot of windows as far as like eating out at restaurants, and our quality of life has greatly increased. We don't have to worry about, labels that say may contain as much. And it's been a great journey through the whole process.
Great, yeah. And so with avoidance, what we have seen sort of with our patients is a bit of a range. I think some patients have been very comfortable with what they're doing with reading of labels, but others have struggled and really have been seeking out sort of proactive treatments. We talked a little bit about oral immunotherapy, and Dr. Gupta shared some of the difficulties with it. And so in that previous patient session, we asked our patients, well, what are some of the challenges with OIT and what might be some of those unmet needs? And for example, some of the options were taste and the smell of the treatment, discomfort from side effects, length of time it takes to be effective, the frequency of visits to the doctor's office when you're doing OIT, or finally, anxiety about having an allergic reaction during the treatment. And as you can see from the pie graph here, very clearly patients, more than half of the patients really identified anxiety about having an allergic reaction during the treatment itself. So we know it can be quite an effective treatment, but there are some challenges. And again, Christy, if you don't mind, just sharing a little bit, you've been part of an OIT program, and what was that experience like for you?
So I'd say that our biggest challenges, Parker's 5 and he's allergic to wheat, egg, and peanut. So the biggest challenges I would say is once we give the dose, trying to keep him calm within that 2 hour window. It's hard with extracurriculars, trying to, keep a 5-year-old calm and not running around. And, so that's our biggest challenge with OIT.
Yeah, thank you so much for sharing that. Because again, I think the data has been clear that it can be quite effective, but there are aspects of it that can make it difficult and really give us even more reason to continue to look for newer, better, faster, safer ways to do these treatments. And so that leads me into our next slide. So again, going back to the idea of, well, trying to understand how does IgE-mediated food allergy work to help us to identify, newer treatments that can be more targeted. And so this slide kind of goes over the basic stages: allergic sensitization, which is that first stage at the top of the slide, where the patient is first exposed to the food itself, or the allergen in this case, and then ultimately develops IgE. And then the bottom stage here, the effector stage. So once that IgE has been developed and it's sitting on the surface of mast cells and other effector cells, then the ultimate reaction happens. And in this picture also are depicted some of the key cytokines and other cells to really try to target other treatments. But really, when you think about this whole process, IgE just easily rises to the top because we know IgE is really dedicated towards allergic reactions. and not really involved with a lot of the other aspects of immunity. And so it just seems to be a likely target. Now, this kind of stepping back for a moment just to look outside of just food allergy, and this slide here it showcases the atopic march. And the reason for this slide is just to remind us of that central role, the importance of IgE in allergic diseases. And so we know for many of our atopic patients that they go through this sequence of actual diseases. So starting perhaps with atopic dermatitis, eczema, eventually maybe with the diagnosis of food allergy, and then subsequently asthma and rhinitis. Two of the biggest studies that have been done in food allergy, the PALISADE study of oral immunotherapy, as well as the PEPITE study of epicutaneous immunotherapy, also showcase this sort of comorbid atopic diseases all triggered by IgE, with 53% of patients in the PALISADE study having comorbid asthma, and 49% of patients in PEPITES having asthma, and 56% having rhinitis. Again, just highlighting that central role of IgE, not only in food allergy, but really in atopic disease. Now here you have a picture of sort of the role of IgE as well as the potential role of anti-IgE. And I'll just say that one of the beauties of an anti-IgE therapy is it's very straightforward for not only patients, but even for providers to understand. And what you see on this slide is on the left half, on where it's on the pink side, you see an untreated food allergic patient. You see the plasma cell in the middle creating IgE and the different places that IgE plays a role, whether on the mast cell, on B cells, eosinophils, or basophils. And on the right, in the light blue side, what you see is where anti-IgE can take effect and how it neutralizes the mast cell degranulation, as well as with the B cell as well. So again, I think it is really important when we're talking about biologics and treatments that may affect your immune system, any way that we can understand it is going to be very important for us as well as for our patients to truly believe in its safety. Now, omalizumab is one form of an anti-IgE therapy, and a couple of early studies, one in 2003 and one in 2011, showed that it could have a potential role when it came to peanut allergy. But it really wasn't until 2017 and since then that there's been a lot more growing interest leading right up till today in the use of anti-IgE therapy for food allergy. I do want to highlight this one study from 2017 by Andrew McGinnity and his colleagues. And here, this was actually a study that was looking at the combination of omalizumab anti-IgE therapy with oral immunotherapy. But here, what I really would like to focus on is the very first part of the study. And so in this part, the patients were started on anti-IgE therapy with omalizumab for 4 months, and then went into what we call this initial dose escalation phase. So those familiar with OIT probably know this is that first day where typically 3, 4, maybe 5 doses of peanut, small amounts, are given to kind of ramp up the immune system in preparation for the longer, drawn-out buildup common in OIT. But in this case, the question was, well, under the protection, under the treatment of omalizumab anti-IgE therapy, can they ramp up much faster? And what they found were starting with a tolerance level of about 88 milligrams, then going on to omalizumab and coming to this 1 day, what you see on the left side of that figure is the median amount of peanut that patients were able to get to on that first day across 10 doses was 250 milligrams, which was in a cumulative sense across all 10 doses, 490.5 milligrams. And all of this is, again, just under the cover of omalizumab. The rest of the study, of course, looked at the combination, but here, just even in this first stage, it sort of suggests that, yes, there could be a benefit to omalizumab as a therapy on its own. This led to the development of 2 larger studies that were submitted to clinicaltrials.gov. First one is the OUtMATCH study of anti-IgE therapy with omalizumab for the treatment of multiple food allergies, and which was conducted by the Consortium for Food Allergy Research, COFAR. The second was the study of ligelizumab for the treatment of peanut allergy. Now, first focusing on the COFAR 11 study, the OUtMATCH study. So this was a study I just mentioned that was looking at omalizumab anti-IgE therapy for the treatment of multiple food allergies. And now, this is a very complicated study with 3 stages, but I really want to just bring your attention to the yellow section, stage 1, which is the part that was recently concluded. This was a straightforward section where patients first had to be found to be allergic to peanut, plus 2 other common allergic foods, and then were randomized to either receive omalizumab therapy or placebo for 4 months, and then came back and had those same food challenges again to show whether they were able to achieve clinically meaningful levels of desensitization after that treatment. And hot off the presses, we're excited to show that just on February 25th of this year, 2024, the results of this stage 1 were published. And here, what they showed were 462 patients screened for this study. Only 180 were randomized, demonstrating just how difficult a study this was to recruit. Of those 180 patients, they were randomized 2-to-1 to receive anti-IgE therapy with omalizumab or placebo. Of note, in the small print you see here, the vast majority of these patients, 177 to be specific, were pediatric, and there were just a handful of adults in the study. After the 4 months of treatment, what we found is the primary endpoint in this study being anchored on peanut. 67% of the patients that were treated with omalizumab were able to achieve the endpoint of tolerating 600 milligrams or more of peanut after 4 months of omalizumab. Again, no oral immunotherapy, no exposure to peanut, only omalizumab therapy. On the right, you see the secondary endpoints representing some of the other foods that were treated. And in particular, you see our efficacy numbers for cashew, for milk, and for egg. The milk and the egg, very similar to peanut, 66 and 68% responders. Cashew, you see a little bit lower there. So something that is of interest to all of us as providers as well as patients of understanding, what does that mean, and how will that sort of show up in real life practice. The other aspect of the study that I think is critical to speak of is going to be the safety. So omalizumab, having been approved almost 20 years ago for the treatment of asthma and almost 10 years ago for urticaria, has been used in medical practice for many, many years with very reassuring safety. And sure enough, thankfully, what we've seen in this outmatch study is that injection site reactions were the most common side effect. And there were very few other severe or significant side effects that came from the therapy. Now, next, we mentioned previously about ligelizumab, which is another anti-IgE therapy. And similar to omalizumab, it also binds to IgE. But in this case, ligelizumab has unique binding sites as well as IgE affinity compared to omalizumab. And so there's a question of, can that have an effect on overall, first of all, efficacy, but possibly also the kinetics of therapy as well? Could it possibly treat faster, more effectively? And an ongoing study for peanut that I had shown you previously has recently been halted, but there's been some discussion and potential for a new study that may be more focused on multiple foods. And so that will be interesting for us to kind of wait and see where that goes. And so here, we would actually like to get your involvement. And so we have a polling question for you. What is most important to you regarding the use of a biologic for food allergy treatment? A, its efficacy in preventing allergic reactions. B, side effects of the medication. C, patient anxiety about needles and injections. D, frequency of office visits to administer medication. And E, length of time patients must take the medication. All right. And so moving forward, thank you for those who are able to answer those questions. And so we asked that very same question to the patients from the patient session previously. And what was their attitude towards biologics? And interestingly, what we see here are 2 different answers stand out. The largest one was knowing that it's actually working, which is just very, again, it's very telling. So in the case of oral immunotherapy, there is a positive reinforcement. The food is ingested, there's no outward symptoms or allergic reactions. So there is a confidence that it is actually doing something. But in the case of a biologic that it may be injected, how will a patient know? So an important question for us in practice to be able to figure out. And in addition, something that I had mentioned previously of side effects of the medication. So any medication that may be affecting the immune system, well, what are those potential side effects? Will it make me prone to infections? Will it have long-term permanent effects? Things along those lines. As I mentioned with omalizumab and 20 years of safety data, we're feeling good about it. We're reassured, but it will still be important because the food allergy population is a different group of patients, and will there potentially be differences? Now, if it's okay, Christy, I'd like to bring you in here and just to kind of get some of your thoughts of, what would you be thinking about with regards to biologics, some concerns or other thoughts you may have?
Okay, so I feel like kids, children with food allergies have daily anxiety to begin with. So I think my main concern would be, the form of injecting it. I think it could create a fear or, stress daily if a child had to do that. So that's my main concern with it.
Yeah, again, thank you very much for sharing that. And I think the injection aspect is, well, of course, to our children is going to be probably a number one, two, and three as
Right.
far as concerns that they may have, but also for parents as well. And understanding that at this stage, we think of this medicine as something that can be quite effective, but doesn't cure the allergy. So may need to be a long-term treatment. So, these are going to be some real considerations that we'll have to have. Again, excited for us to have this available for us to use in practice, but again, lots of questions that will need to be answered. Now, going back to the poll, thank you again for everyone for participating. And sure enough, what we found is even amongst our providers, we see the same sort of concerns that the patients have shown. So, what are the side effects of the medication and are we knowing that it's actually working? So some of these questions that both in the research realm, but also in the clinical realm now, we're going to try to answer to help us move forward with this. Now, again, we just heard from Christy, injections, side effects, these are some concerns that people have. And so I don't think we're done in the world of looking for other types of treatments. And for those patients that perhaps they have that strong oral aversion or concerns with oral immunotherapy, or ones who aren't interested in an injection or some sort of immune medicine, what are other options that are in development? And one I would like to highlight here that was previously mentioned by Dr. Gupta is epicutaneous immunotherapy, also known as EPIT. So in this case, the picture here tries to show you sort of how this particular model of EPIT works. And so what we have here is going to be this plastic film with a foam ring on the underside of it. And underneath that plastic is going to be peanut that is dried on. The concept is that this patch is applied with a good seal, and then perspiration from the patient's skin will then solubilize the peanut that is on the underside of the patch, which is then able to diffuse into the skin and access those important immune cells that are right there at the surface of the skin. One of the key aspects of this treatment is ideally keeping the food allergen, the treatment, at the level of those immune cells, but not into the bloodstream, hopefully minimizing sort of the systemic absorption, and hopefully also in that way controlling the risk and safety. After a couple of positive phase 2 studies, the PEPITES phase 3 study, a multinational study, was conducted. And this is the graphical abstract from that publication in JAMA from 2019. And what you see here is 31 international sites, 218 boys, and 138 peanut allergic girls were involved in this overall study. And what on the right side, you see the actual findings of the treatment. So 35.3% of patients that were on the active peanut patch were responders by their criteria, whereas on placebo, only 13.6% were considered responders by that criteria. The difference between those two was 21.7%. And it's that difference there that did not meet the original criteria of the study. So this was actually considered a negative study, although more patients on the patch seemed to be responders. So although sort of a discouraging result, the patches continued to be studied. And there was a question of, well, does age matter? And so we've seen this with the early introduction of peanut that Dr. Gupta shared with us earlier. And studies of other therapies, oral immunotherapy as well as sublingual, have suggested that perhaps if you can treat younger, that immune system of those young children may be more open to change and maybe more likely to be desensitized and tolerized. And so can this epicutaneous patch work in toddlers? And here you see the recently published findings from the EPITOPE study looking at 1 to 4-year-old peanut allergic patients. The patch was exactly the same, and the dose 250 micrograms was the same as in the older children's study. And here what you see is, sure enough, there was a stronger response. So on the left in the light blue, what you see is a 67% responder rate after 12 months compared to 35% in the older kids. The placebo response rate did increase at 33%, but that difference of 33% did meet the criteria that was established from the study, showing that there was an effect a positive effect from treatment. In addition, we looked at the adverse events. So we always care about adverse events and safety, but especially when we're going to the youngest kids, these 1, 2, 3-year-olds, we need to know that this is safe. And what they found was, well, everybody on the patch, whether it's treatment or placebo, did have some form of side effect. And the majority of side effects people saw were just from the patch itself. So right at the adhesion site, there may be some redness or itching. But most importantly is the far right side of that graph, where we see anaphylactic reactions. And sure enough, we see very, very few kind of fitting in with the model or the concept of this therapy being primarily focused on the skin with minimal systemic absorption. Now, it's key to understand that with any type of immunotherapy, including epicutaneous, we are intentionally exposing our patients to what they're allergic to, in this case, peanut. So that risk of an allergic reaction is always going to be here. So whether we're talking about oral, sublingual, or epicutaneous, it will be critically important for all of our patients and providers to remember this and to understand that epinephrine still needs to be available and avoidance still needs to be practiced. But hopefully these therapies, as well as the biologic therapies we've talked about, can create sort of that added buffer so that in that case where we're doing all the right stuff, but an exposure happens that we didn't expect or didn't intend, that can protect us and either prevent the reaction in the first place or at least decrease the severity of that type of reaction. All right. And okay, so some additional resources for our patients and their caregivers. You see some of those listed here: the Asthma and Allergy Foundation of America, Food Allergy Research and Education, the FAIR Group. We see Dr. Gupta's group, the Center for Food Allergy and Asthma Research, as well as the National Institutes of Health and the National Institute of Allergy and Infectious Diseases. And their links are here for more information. And with that, we will move on to a few. I think we have a little bit of time for a few questions. And wow, we have a great number of questions. So again, thank you so much for everyone listening in and for these great questions. And we will, let's see which ones we can hit.
Let's see.
Dr. Gupta, if it's okay, I have one question that I'd like to pose to you that is important to everyone who lives with food allergies, including myself, and I think you as well.
Yeah.
It says, do you foresee a future where the may contain type of labeling becomes more standardized and legally required? Because this has been very much the frustration of so many families that are out there with food allergy.
Absolutely. And this is something we're working very hard on. And if you want to be a part of it, please reach out. What our hope is to get threshold levels put on different items. So instead of saying may contain, it would be a threshold up to a certain amount. So 0.05 is one of the ones we're going with. But that would require allergists to be able to tell their patients, either do small challenges with very, very minute doses. That would then allow them to freely eat PAL. So we are trying. We're actually doing some work surveying individuals and as well as allergists to see if this would be a viable way. But we do need to change that. I want to give you, Dr. Kim, some time because I know there's a lot of great questions with the exciting new research on Zoller and OIT.
Yeah, thank you very much. And so, yes, very much a long list of questions there that are here. One simple one we can hit on specific to this anti-IgE therapy and omalizumab. It asks, do we know as of yet if there are long-term side effects of IgE-targeted treatments? And like I mentioned previously, in the specific food allergy population, not yet. But when it comes to patients with asthma or urticaria or even chronic sinus disease where omalizumab has been approved, thankfully, even in patients on multi-years of this therapy, we've not seen long-term side effects with regards to the immune system or really otherwise. We do know that, again, injection site reactions are common. For some patients, they get better. For others, they may persist. And there is a very, very small chance, but a chance of anaphylaxis itself to the medicine itself. And so the way that it's going to be prescribed is that the first 3 doses at least will need to be done in a healthcare provider's office. And once there's an assurance that it is well tolerated by that patient, there actually is going to be the option for patients to home administer this. But again, in this new population, it'll be important for us to track this very carefully and make sure that in our highly allergic population that we don't see a different signal that we need to be aware of.
There are so many more for you if you have some time. A lot of questions around. There's one about milk treatments, because we talk a lot about peanuts and EPIT and oral immunotherapy, but one great thing about this new treatment, omalizumab or Xolair, you want to talk about what the results were in milk?
Yeah, so thank you very much for that question as well. And so what we saw within this OUtMATCH study, where again, patients had to be allergic to peanut plus other foods, and milk was one of those, we saw the numbers, the percent responders for milk, very similar in the range of the upper 60%, similar to what we saw for peanut. Now, one thing that I will bring up though is that the bar actually for the non-peanut foods, including milk, was slightly higher. So for peanut, they had to be able to tolerate at least 600 milligrams, 2 whole peanuts worth or more. But in the case of milk, they actually had to be up to 1,000 milligrams, as well as egg and some of the other foods. But even with that higher bar, what we found was almost 67, 68% of patients that were on omalizumab were able to tolerate that much or more of milk, suggesting that it does work across different